But anyway, let's jump into non-STEMI and STEMI. We're going to cover in one session here. And most of this is going to focus on things that have changed, that changed in the last year compared to the earlier, I think 2002, 2004 recommendations. There are a few articles that are strange out there. One of the strange articles, and there's a few of them that show the same thing. We all know if you have a lot more risk factors, you're a lot more likely to have heart disease. But when they looked at this in the emergency department to see who has MIs and who doesn't, there doesn't seem to be an increased number in people with risk factors compared to not. So the conclusion of the authors is risk factors don't matter. But probably what's happening is if you think someone's more likely to have something because they have risk factors, you're more likely to admit them. So you'll admit twice as many of the risk factor group as you do the non-risk factor group. So when you mathematically look at the number of instances across all the groups, it comes out the same. And that's because we're good at making those adjustments. I'm curious as to if anyone here has difficulty picking out the person who has heart disease versus not. I have on occasion had difficulty trying to figure out whether a chest pain is for real or not. And I think for many of us it's been historically a source of contention between emergency department and other services. Because we ask the question, am I sure you're normal? And they ask the question, well, do you have the disease I'm interested in? So there's a big gray area in between there. I would, if you want to, the most wonderful series of articles on this subject were done by Lee and Goldman. They were done in the 80s, I believe, either early, mid-80s to early 90s. I think it was more mid-80s. It was a 5-center study. Everyone over 18 years old with non-traumatic chest pain was entered into the study. Everyone that was entered into the study, if they weren't admitted, they were called back in the next day or two, re-examined, repeat cardiogram, repeat enzymes, and the ones that died, they tracked down to and tried to see what was what. In this study, you were enrolled when you arrived in the emergency department, and I would capture the following information on you. Your age, your demographics, your risk factors. Did you have nausea? Did you have sweating? Did it radiate to your left arm? Did it radiate to your right arm? Did you have reproducible chest pain? Did you have belching? It went through this whole litany of things that we look at that sort of help, we believe, help discriminate what's real and what's not. So some things, for instance, that they found, indigestion, quote, unquote, was equally frequent in people who had heart disease versus not. Belching had the exact same instance in people without heart disease versus those that did. Overall, they sent home 2% of all the MIs were erroneously, supposedly, discharged. And of that 2% that were discharged, they tended to be less dramatic cardiograms, more equivocal cases, and had a 25% mortality rate. So there was something that happened different at home than happened in the hospital. Now, of those 5 centers, one center had 0 discharge. It had 0 MIs that they could identify that they erroneously discharged. So what was the difference between that center and the other 4 centers? The average number of, the percentage of patients admitted in those 4 centers was about 50%. Of all comers over 18 years old with unexplained chest pain or explained chest pain, 50% were admitted. And at William Beaumont, which was the place that missed none, they admitted 70%. So by adding another 20% to the fray, they wiped out that last 2%. I think that's a great article to pick and pull out the information in it and plaster somewhere in your emergency department. Along with that, are the TIMI scores that are listed here, along with what those TIMI risks mean. Now here's an example of 2 people that are TIMI 3. I'm over 65 with 3 risk factors and I've taken aspirin in the last week. I'm a TIMI 3. Here's another TIMI 3. I've had 2 severe anginal events in the last 24 hours. I've got increased troponin and cardiogram changes. That's also a TIMI 3, according to this, assuming everything else is negative. One thing about scoring systems is that you can produce scores that are nonsense because because of the way the information is collected. You can do the same thing with the pneumonia score that you use for admitting people versus discharge. I got a chart kicked back to me because the pneumonia score was low on this patient. It was a young, healthy person with pneumonia. The reason he was admitted was probably stupid on my part, but his blood pressure was 60 over palp. And so I thought that was a good enough reason to admit him. But he didn't have, his labs otherwise were normal and all this, and his pulse ox was great and everything. So when you look at the pneumonia score, the chart extractor said, well, the pneumonia score is very low. What did you admit him for? So you can get ridiculous sort of circumstances. Nonetheless, when you use TIMI scores and they start talking about low risk, moderate risk, and high risk, and you are questioned about why are you admitting low risk patients, your first question back should be, tell me what your acceptable miss rate is. Is it 50%? Is it 10%? Is it 1%? They'll usually give you a low number, a couple of percent. So these are the TIMI combined endpoints. So based on your score, this is your risk of having either death, new or recurrent MI, or urgent revascularization. If your TIMI score is 6 or 7, you got a 40% chance of one of those things happening. If your TIMI score is 0 to 1, you have about a 5% chance of one of those things happening, which is why all of us in the room get stuck with patients that have unexplained symptoms of which cardiac could be a possibility. But these, I think these are very useful numbers to remember. And what the low risk means, it doesn't mean if I have acute coronary syndrome, I've got a low risk of something happening. No, once I have acute coronary syndrome, I'm just as much at risk as anyone else having it. But out of the 20 of us, only one of us is actually going to end up having the real thing. There's a paragraph here that talks about troponins and gives you the shocking results that people who have very high troponins tend to fare worse than people who don't have very high troponins. So if that's a shock to you, that's a take-home message for you. Now we jump into the treatments. Many of the treatments are the same. Nitrates, do nitrates decrease mortality in MI? And if you look at literature from the 60s and 70s, it actually did. In the literature of the last 20 years, it doesn't have any impact on mortality. That's probably because we have other drugs that are impacting on mortality to a greater degree than nitrates. If you're giving someone sublingual nitro, and you did serum levels on them, they would have the same serum levels as somebody on 20 to 30 mics per minute. So it really doesn't make sense. If somebody's able to tolerate sublingual nitro, it doesn't make sense to start them at 10 mics a minute. You ought to start them at 20. In my training, and I trained first in internal medicine, and this was very aggressively pushed, that when we put people on nitro drips, anytime we would change the drip, we would bolus the patient with a sublingual nitro. So if I went from 10 to 20, the cardiologist said, no, if you just go from 10 to 20, it'll take 15 minutes or so for them to equilibrate. So you want to bolus them up to the next level and then do that. Does anybody else in this room do that? I think there's like 3 of us in existence that currently do that. But hopefully someone will take a look at that someday. Obviously, worry about the nitrates if somebody is on Viagra, and I'm sure I'll just ask, of the last, can anyone say here, can anyone raise their hand and say for sure, the last 10 men they treated and gave nitro to, they asked about Viagra beforehand? Is anyone consistent about doing that? Shame on us. Has anybody given nitro to somebody on Viagra? It is ugly. It is ugly. We had somebody that was profoundly hypotensive. One of my colleagues tried 1 mic a minute and made the person profoundly hypotensive, so be careful. Morphine, the only evidence for morphine is that it increases your patient satisfaction scores. There's never been any data that it is helpful. There is data that it's harmful, but that's probably just by accident. Is that the worse off you are, the more likely you are to need morphine, and therefore there's a correlation. There does, however, seem to be some pretty reasonable literature that if you have a severe congestive failure or pulmonary edema, and you would rather intubate them than pull them out of it without intubating them, then give them morphine, because it markedly increases the need for intubation. Okay, here's your big change is with beta blockers. Beta blockers was something you gave to everybody unless they had a florid contraindication. They had heart block, they were in severe failure or pulmonary edema, but the wisdom was, oh, moderate failure? Good, give the beta blockers. For everybody, right when they hit the door, they should be given beta blockers. You should be giving them IV beta blockers. Oh, the person that has the heart rate, the sinus tachycardia, oh, that's the best person to give the beta blocker to calm them down and quiet them down. Now again, going back to my training, I remember a huge grand rounds we had on sinus tachycardia in acute MI. It was a grave prognostic sign. The belief at that time, which was supported by some great literature, is that you could not clinically at the bedside distinguish the person who had sinus tachycardia from sympathetic overdrive and the person that had sinus tachycardia because of occult pump failure. And therefore, at that time, it was an indication to put in a swan to measure cardiac outputs and see what was going on. Subsequent to that, I don't know what day this happened, but that was just declared to be irrelevant and never happened. And now with this last rendition based on the Commit trial, which was a Chinese trial of 45,000 patients with MI. So this is not unstable angina. This is with people with either non-STEMI or STEMIs. And most of them had, I think 93% had STEMIs. Is now they're back to sinus tachycardia, slow down. It's a serious prognostic sign. They don't automatically get beta blockers. So now the position is anyone with contraindications, most of which have to do with failure, age, you can read it in the text, those patients should not be given IV beta blockers, and for the most part should not get beta blockers in the first 24 hours. The perfect person to give beta blockers to early on is the person that's having the STEMI, that has hypertension and has no contraindications otherwise to beta blocker. Then the beta blocker is perfect both for their STEMI plus their hypertension. So that is in the door what you give. Now, in terms of the benefits and the harm, the benefits that were found was you prevented recurrent MIs and you prevented VFib by giving beta blockers. But you worsen cardiogenic shock. And this is how it's played out in the Commit trial, is that the cardiogenic shock was on day 1, and the benefit from the beta blockers was on day 2, in terms of preventing recurrent MI or VFib. So the conclusion of their study was, don't rush, hold off on day 1 unless there's a compelling reason to give it. So now it's flipped. Instead of you have to find a compelling reason not to give it, you have to find a compelling reason to give it. And otherwise hold off. It is a recommendation that before they leave the hospital, you search for an opportunity to put them on oral beta blockers. And if they have congestive failure, oral beta blockers continue to be an important regimen to put them on at very low dose. As an aside, I've not read much literature on this, but our cardiologists are very adamant about this. We have one guy that runs a congestive failure, the whole congestive failure franchise for our institution. And they put a lot of people on beta blockers. And they go through a period of time where they really have difficulty on the beta blockers. They're really teetering on worsening failure, but over time they slowly get better. Now what happens is sometimes that they get a little too bad, so they come to the emergency department. And at least from their view, what we can do to screw up the works is now slam them with drugs and over-diurese them and create this enormous sympathetic outflow, and we've set them back to ground zero. So what they really beg for us to do is just treat with nitrates, treat very gently, don't diurese them at all if we can avoid it, or else just very gentle diuresis. They are also, I welcome this guy because he's also one of the few people that use Lasix in a way that I like to use it, which is 20 to 40 milligrams and never a higher dose than that. I don't know if you remember why Bumex came onto the market or what the selling piece for it was, but people with congestive failure on Lasix, the worse failure they had, the more problem they had with absorption of the Lasix. So you'd have to give them higher and higher doses in order to give them basically a bioequivalent dose. And the beauty of Bumex was that you gave them 1 milligram, they absorbed 1 milligram, and they used the whole milligram, and everybody was happy. So when you see somebody that's coming in that's on 80 milligrams of Lasix, 160 milligrams of Lasix, many of us in the room have this practice of, oh, whatever they're on orally, let's give them IV. That's not what their body's used to. Their body is used to actually a very low dose of Lasix. And if you give them a high dose, you have a negative effect the first 25 minutes to a half hour in a pulmonary edema, and then you end up over-diuresing them later. Anyway, that was a long-winded way to talk about beta blockers. Calcium channel blockers, nothing else has changed with calcium channel blockers. They're the second-line drug. That nifedipine is an evil drug for coronary disease, still is there. ACE inhibitors have not had any change in their indications, primarily for congestive failure. Stop all the COX-2 drugs and the NSAIDs. Anticoagulants and antiplatelets. Please remember that the studies on aspirin show that everyone benefits from aspirin except people that have, fatal anaphylaxis to it. But everyone, including people that don't have heart disease. If you're 40 years old or over, you benefit from taking an aspirin a day. So you're not required to have any good evidence of heart disease in order to take aspirin. But once you start to add these other things, Plavix and anticoagulants, the studies that have shown that they work are studies where patients are pre-selected that have very high risk. So I either have positive troponins or I have unequivocal dynamic STT wave changes on my cardiogram. So when you study that population, you show a benefit from Clopidogrel, you show benefit from heparin and from enoxaparin, but you cannot expand it from that population to a less sick population because the benefit decreases, but the side effects don't. So you increase your risk of having an adverse effect. There is one wonderful study that was just done in New York that I use all the time for what I like to talk about most, which is crowding and hospital flow and whatever. The number needed to reduce to a combined endpoint with aspirin is 1 in 20. For every 20 patients that you treat, you prevent a bad outcome. And for every 40 patients, you prevent a death. That's great. And CMS focuses on that, and they got this huge thing. And I met with the CMS medical advisors in December, and I was giving them a talk, my song and dance routine on crowding and moving people out of the emergency department. And I said, you guys devote your life to making sure we give aspirin to everybody. And we save one life out of every 40. And there's just this study from New York City on ambulance diversion where they looked at mortality rates of acute MIs during times of diversion versus times of no diversion. And they attributed 1 out of every 20 deaths from MIs to ambulance diversion. So you have all this effort of CMS devoted to making sure we give aspirin where we save 1 in 40, and you're doing nothing to look at diversion and crowding, which kills 1 in 20. So I thought that was... So they actually are going to put together a task force on emergency medicine now, and they actually want to ask the question, I understand, what's actually important to our environment? Is it really the stool guaiac that's making people drop like flies, or are there other more important things we need to focus on? The timing of the Clopidogrel, there's no evidence that it has to be given at triage or the very first second you see the patient. And there's no absolutely clear evidence that it has to be given right away. So it is unclear whether, and some hospitals will do this, they say, wait until we get the angiographic data, because if the patient needs CABG, then we can send them for CABG now without complication. Because the rate of re-exploration if you're on Plavix is, I think, increased by a factor of 30. If I remember the number right. But it's quite a dramatic increase of bleeding complications. For STEMIs, the same beta blocker stuff applies, and the differences in STEMI is that now PCI within the first 90 minutes is officially a Class A recommendation. So anytime you can get some door to balloon of 90 minutes or less, that's what they should get. And a lot of stuff that goes with that, should they get aspirin, should they get Plavix, should they get heparin, beta blockers, all that sort of stuff is unclear. But what is clear is that they go directly for PCI. 2 weeks, 3 weeks, 4 weeks, 6 weeks, 12 weeks, 24 weeks, 36 weeks, 48 weeks, 52 weeks, 53 weeks, 54 weeks, 55 weeks, 56 weeks, 57 weeks, 58 weeks, 59 weeks, 60 weeks, 61 weeks, 62 weeks, 63 weeks, 64 weeks, 65 weeks, 66 weeks, 67 weeks, 68 weeks, 69 weeks, 70 weeks, 71 weeks, 72 weeks, 73 weeks, 74 weeks, 75 weeks, 76 weeks, 77 weeks, 78 weeks, 79 weeks, 80 weeks, 81 weeks, 82 weeks, 83 weeks, 84 weeks, 85 weeks, 86 weeks, 87 weeks, 88 weeks, 89 weeks, 90 weeks, 91 weeks, 92 weeks, 93 weeks, 94 weeks, 95 weeks, 96 weeks, 97 weeks, 98 weeks, 99 weeks, 100 weeks, 102 weeks, 103 weeks, 104 weeks, 105 A level B recommendation is, what if you can't get them for PCI within 90 minutes? Well, then they recommend that thrombolysis within 30 minutes is an acceptable treatment. There is a mix of data on this. There's a nice study in France that showed that even people getting to a lab within 3 or 4 hours did better than the alternative. And remember that thrombolysis only works about 70% of the time. So you're still stuck with a substantial population that are not responding to it. There's been an effort to look at facilitated PCI. We have this delay. We can't get them there in 90 minutes, so let's add other stuff to it. Full dose thrombolysis, partial dose thrombolysis, Plavix, heparin, 2B3As, all sorts of other tricks like that. And there's no level A evidence for what should be done. What does seem to be true is if I give a full dose thrombolysis and then send you to the lab for PCI, that's more dangerous than not giving you the thrombolysis. If you do reperfusion therapy, the recommendation is that you give heparin at least for 48 hours, preferably for the entire hospitalization. And the other, I forget if it's a level A or I think it's a level B, is that if you're going to give it for more than 48 hours, switch to enoxaparin or fondaparinux so that you can decrease the incidence of heparin-induced thrombocytopenia. And Clopidogrel, the new recommendation is if you're having a STEMI, you get Clopidogrel plus aspirin regardless of what option you use, whether you use PCI or thrombolysis or whatever else. All of them get the Clopidogrel. And how long should you give it? Level B evidence suggests 14 days. There's some other literature that's coming out that's saying you should just be on it for the rest of your life. They're doing a randomized trial of either you being on the drug for the rest of your life or just giving the company money for the rest of your life, and they'll see which one of those turns out to be the best. There's a peculiar study where people that stopped the drug had a higher death rate. I've heard Rick and Jerry talking about that. I've not read the article myself yet. Is anybody familiar with that study at all? So that might lend fuel to the fire to continue it for forever. And obviously, once on aspirin, always on aspirin forever unless you get a clear contraindication. So at that point, any arguments or comments or disagreements or food fights or anything? You got a little beer in you now, so you can get a little frisky. No? All right, well, thank you. Yes, okay.
You didn't mention differences between men or women in any of these recommendations. Are there any studies that speak to that, or is it just not available?
I did not see any recommendations that were different, and I honestly don't know of any that are different. The literature, as you know, is an ongoing testimony to, for whatever reason, women getting treated less aggressively. And what's bizarre is that they get treated less aggressively even when you know the disease they have. Are you familiar? There's this absolutely incredible study that was published in the Annals of Internal Medicine a number of years ago. And here's the study, is that we're going to get all you together. You're a bunch of internists and cardiologists. And you're about the mix of what you are now in terms of sex distribution. And I'm going to show this half a video and show you guys a different video. It's going to be the same woman. She's going to use exactly the same words, except they're going to see a video where she's emotionally calm and very eloquent and very conservative. You're going to see a video where the woman's a lot more emotive and agitated with her symptoms. And you're both going to judge whether or not you think it's cardiac and whether or not they need to get worked up. You think, after watching the video, 50% of you think she needs to be worked up. When you guys see the video, both men and women in the group here, 10% of you think they need to get worked up. That's part one. Now we're going to do part two, which is not quite as amazing as part three. Here's part two. I'm going to give you all of you additional information. Her cholesterol is 250. Her first episode of chest tightness was when she was running for the bus with her child, and the second episode of chest tightness was when she was arguing on a phone, and she's got a strong family history of heart disease. Now, both groups, having been given that information, 90% of you believe now that this is probably cardiac, and 90% of you now believe that this is cardiac. Here's part three. What are we going to do? 90% of you are going to work her up, and 50% of you are going to work her up. That was the results of the study. Even more amazing than the study was the editorial. The editorial was written by a guy, and this guy says, see, this proves that body language actually teaches, that the physician can actually extract something important from body language and not be fooled into thinking somebody has real disease when they're really just hysterical. It's the most amazing article and editorial to read in medicine. It's like the woman's answer to the Tuskegee study. It was just unreal. Anyway, this is I don't honestly see it amongst my colleagues, amongst us. I don't see that. And so I was baffled by the literature until we went through a period in our emergency department where the cardiologists started coming down and seeing the patients, and I actually got to see them see the patients. I admitted one woman for a rule-out ACS, and the cardiologist came down, didn't even take a history on her, just walked in the room and said, well, it's clear this is indigestion, we're going to send you home. This is the case. She's a 55-year-old woman. She's a schizophrenic. She has a very flat affect, and she came, and this is basically her story. Hello, how are you? I have diabetes, hypertension, high cholesterol, and smoke cigarettes. And yesterday when I was going up the steps, I got a tightness in my chest that went to my jaw, my left arm, and I sweated and was short of breath. I stopped and it went away in 5 minutes. It happened twice yesterday. Today it happened for 45 minutes. So I thought maybe I was having a heart problem and came to the emergency department. And my affect is almost a perfect replica of her affect. And the cardiologist just walked in and said, you're fine, see you. And it was instructive to me to actually see this and see it to repeat itself as well. So we have to defend our patients against the ill winds out there.